The problem when you're asked to talk about the NHS reforms is to say, well, you can attempt to try and make some sense of it. Or you can just say, actually, this is a dog's breakfast and I'm not going to dignify it by trying to make sense. It's a bit like the position of the people who used to sit around the oracle at Delphi. And there would be some obscure statement that would come out from the oracle, and then they would spend their time interpreting this meaningless garbage for the rest of the world and applying it in some way as if there was some rationale, or a medieval sovereign, a medieval king or queen who would come out with some nonsensical statement because they'd been breeding with their cousins or something like that, and the court would try to make some sense out of this as if it actually meant something. And I'm afraid my view right from the very beginning, and I wrote a paper in the BMJ, some of you might have seen, which was rather tongue-in-cheek. It said, well, I have to teach health systems. And last year I was teaching I had to learn up on on the Affordable Care Act in the US. I had to make sense of that and I had to present that to my students. And now I've got the Health and Social Care Act. What am I going to do? How am I going to simplify this in a way that can be comprehensible to my students? And then I went through a whole series of contradictions, because there were lots and lots of contradictions in the Act. And Andrew Lansley, or somebody writing on his behalf, actually replied. And next week in the BMJ it was Andrew Lansley replies, and there was an attempt which was charming in its it had elevated patronising behaviour to a really high level. So it commenting on me, it said, well, some people do have difficulty understanding health systems and they can be very complicated. I hesitated. I felt it would probably be inappropriate to reply that whenever the Chinese government asked me to evaluate their reforms last year, and I thought perhaps they might have thought I knew something about it, but I left that one. And it then went on to say, well, it's actually all terribly easy, it's straightforward. The problem was, of course, that what he said in his piece was actually contradicted by the legislation, which I then pointed out in a final rebuttal, and at that stage we gave up, because, there is a time when you just sort of give up trying to flog a dead horse. So we now have a situation which I think by common consent is totally incomprehensible. And it's really completely futile in trying to make any sense out of it, because you can't make any sense out of it. And some of you, I know, read Roy Lilly's emails that come out on his blogs every few days. I know that we were talking about it the other day, and he probably is the only person in the country who actually understands it. And he understands it by putting it into sort of satire and with nicknames for the key people and so on, and using a sort of rather humorous way to do it, and pointing out the lunacy of much of this. So what can one say? And that's why I thought it might be helpful to be more interactive, because I'm completely stuck. I cannot explain this. We have tried to explain the political economy of it to some extent in some of the papers we've written. Where did the ideas come from? Now, I have to be careful what I'm saying, because one doesn't want to betray medical confidences, but I have to say that, as I mentioned yesterday, within the Conservative Party at the minute, who are wondering how the hell can we keep this off the front pages with an election coming up, they are actually questioning the sanity of some of the people who were involved. Sotto voce. I mean, it's got to that level where they're saying, how did we let this happen? And seriously raising questions along those lines. Now, I don't want to go too far down that route, but it was an abject failure of parliamentary scrutiny for this ever to have happened. Now, of course, in the old days in New Zealand, when you changed things all the time, we looked. You had even fewer checks in the executive, and you could make laws all the time and every day and so on with great rapidity. We're the sort of next most rapid law-making jurisdiction in the world, and we do have a problem. Lord Wolfe, a former Lord Chief Justice, described the process of legislation in the UK as binge lawmaking. And on another occasion, the Supreme Court said that although we do not want to abandon our judicial responsibilities, it is beyond the collective wisdom of this court to understand what was going through the minds of the members of Parliament when they enacted the law. And we have a whole catalogue. There's a book called The Blunders of Our Government, looking at both Labour and Conservative governments. It shows a whole series of things, IT, procurement disasters, and, all sorts of things. Aircraft carriers. How have we got to the situation where the United Kingdom is in the process of purchasing 2 aircraft carriers without what would normally be a normal prerequisite for an aircraft carrier, aircraft? So, as one MP said, the clue is in the name. And we were lucky we even had them, because at one stage we were going to build the aircraft carrier in a dock in Scotland on the wrong side of the Forth Road Bridge, and it wouldn't have been able to get out of the Forth estuary. So we actually have surmounted that one. But what it said was, and what was really interesting in the conclusion to it, was that as they went through all of these disasters, one after another, Labour and Conservative, what was striking was that Parliament had contributed nothing to scrutinising the legislation and improving it. There was no evidence in any of these cases that in all this detailed examination of the legislation had there been any positive impact from the members of Parliament. And that's where we got to. So how did we get here? We, Lucy Reynolds and I, dug out some work from 1985 by two people who then went on to be cabinet ministers, Oliver Letwin, who's a minister in the Cabinet Office in the UK, and John Redwood, who is a former Secretary of State, and he's now on the back benches. And they wrote a pamphlet in 1985 called Privatising the World. And they set out a vision for how to privatise everything, essentially. And their view is that the only things which should not be privatised are the judiciary. Not the courts, they can be privatised, but the actual judges, they felt, should probably be in the public sector. And the management of the intelligence services, much of the rest of it could be privatised. And everything else could be run by the private sector. And that was their vision. And their vision for the NHS was essentially create everything in a way that it can just progress. Because they knew that if they said, we're going to privatise the NHS, you'll never get elected on that. That will never be, you'd never get votes. So the argument in this pamphlet, which they is available, was to do things by stealth, to give more and more autonomy to hospitals, to create an internal market, to create a purchasing system, and so on, and progressively move to privatisation. And in fact, it has to a large extent followed the blueprint. The problem arises, and we had Michael talking yesterday about military campaigns. If you are going to do something, you have to communicate to the people who are meant to be doing it what it is you want to do. And if you can't actually tell them what you really want to do, because they wouldn't do it, you have a problem. So if Montgomery, whenever he was getting ready to go into El Alamein, had said he had a clear vision as to where he was going to deploy his tanks, and it was absolutely clear, getting all the supplies up and everything else, but in fact he told his troops, actually, we're going to invade, I don't know, somewhere, Iran or somewhere like that, somewhere completely different, they wouldn't have known what to do. There is a real problem when you know what you want to do, but you can't actually tell the people what it is that you want. There was, in the initial legislation, a relatively coherent plan which was permissive legislation. So within it, it could have continued the status quo, essentially with an internal market, purchaser-provider, or it could have led to the privatisation of absolutely everything. Now, there were a few clues in it, because there were bits in the legislation that you said, well, actually, these seem quite unnecessary if you're going to maintain the status quo, like the clinical commissioning groups, the purchasers which took over from the primary care trust, instead of being geographically defined as they had been before, so if you lived in an area, that was who purchased care on your behalf, they were no longer geographically defined. In theory, according to the legislation, anybody in the country could sign up with any clinical commissioning group anywhere. So that was quite interesting, because that was a radical departure from where one, what one might think, because the idea was this is just an incremental change. It was sold as this is just giving general practitioners a bit more power, and nothing more than that. It's not a major change. Now, of course, the lie was given away whenever Sir David Nicholson, who was the Chief Executive of the National Health Service, said that this minor tidying up of legislation, which by this stage ran to 400 pages of new laws, was so large that you could see it from space, which again was a sort of contradictory message. But I think what was expected was that this would permit a situation whereby in due course the commissioning support units, which were sort of there to support, they would have all the technical capacity, the billing capacity, the computers, the information and so on. They would in due course morph into competing insurers. And all of the provision would in due course be fully privatised, because there was no mechanism, there was every opportunity for the private sector to come in and bid for a contract for provision and take it, but no opportunity in the next round then for the public sector to go back and compete because it was gone at that stage. So there was a sort of ratchet mechanism. And I think that was the vision that was actually held. Now, then people began to say, well, hold on a minute, I don't understand this, what's happening, because there were so many contradictions. The government was saying, well, it's only a minor change, we're just giving GPs a bit more power, which they could have easily done in the old system by putting a few more of them onto the board of the primary care trust. But then you had these hundreds of pages of legislation and the chief executive saying it was so large you could see it from space. And so the government was then pushed into a pause, a listening pause, which was a purely cosmetic exercise. But what it did do was that it forced them to bring some of these contradictions out into the open and put in place some mechanisms which were superficially meant to be in some way protective. Now, this actually, it doesn't even begin to do justice to the complexity of the system. It is much more complex. There are organisations like Monitor, which is there to enforce competition, although we have a separate competition commission. But this is problematic because the government now doesn't want any competition because it's got an election to win. It's got a Care Quality Commission, which is so completely committed to quality that it's just appointed 120 unqualified quality inspectors. Most of whom many of whom actually have previously presided over failures of quality in their own organisation. So here we have this situation that really nobody knows what to make of. Public health was interesting. The rationale for public health was that we will put it into local government because that's where all the decisions are being made and that's where it had its roots, forgetting, as we showed, that if you look back to the 1970s when it was in local government before, it was frankly hopeless. There were the few individuals in the country who made a difference, the odd district director of public health, like Paddy Donaldson, Sir Liam Donaldson's father, one or two, but most of the time it was not. It was corrupt. There were all sorts of problems. And those were in the days whenever local government did lots of things. So it ran schools and it ran, the waste disposal and so on, before everything had been privatised. So essentially we now have local governments like Westminster that is really one giant car parking company. I mean, that's really all it does. It collects parking fees and does virtually nothing else because everything else has gone. We talk about easy councils like EasyJet, where everything else is an optional extra. So here we have this, I'm not joking, actually Barnett called itself Easy Council. And so here, and then they move forward with the pause, and with all the bits that were put in, they were put in as sort of checks and balances, but there were checks and balances against things that the government said they didn't want to do anyway. So it didn't make any sense. And you now have this situation where, and the problems that are arising are, for example, I talked to my colleagues in the clinical commissioning groups, and you're saying, who's responsible for commissioning care? Clinical commissioning groups or NHS England? Which bit is specialist, which bit's not specialist? And that's a question that they're asking themselves. So they spent 80% of the meeting working out whether they're actually meant to be commissioning the thing that they're talking about in the first place. And they're saying quietly, I hope to God nobody takes us to judicial review, because there is no way, if you just get the minutes of this meeting, you'll see that basically it's making up the rules as we go along. They haven't a clue. So what's been happening? I think the government had an idea that the clinical support, the commissioning support units would ultimately become private insurers, and linked to this was the idea that everybody would have a personal health budget. So essentially, and this was all about empowering patients and empowering people with long-term conditions initially, but ultimately rolled out to everybody. They would say, you know better than anybody else how to manage your long-term condition. We will give you a sum of money and you can purchase whatever you want, and you might want to use that money to purchase some home help, or you might want that to purchase some relief from your family, or you may want to do all sorts of other things, never mentioning what happens whenever the money runs out, and totally ignoring what had happened elsewhere. Now, I have to say, we spend much of our lives preempting these things by writing things in the BMJ because we know what they're thinking. We think we'd better actually get something in print first of all. So we did do a piece looking at the personal health budgets in the Netherlands, which have been a disaster and which have been rolled back because every snake oil salesman in town comes around to these elderly, vulnerable people and sells them Rikai and laying on of hands and putting hot stones in their back and selling them iPads and everything you can think of. And think of mis-selling of insurance policies. Think of all the things that go on. This is just a recipe for con men. to be perfectly honest. So the Netherlands have radically pulled it back. But the idea is that if you move towards a personal health budget, ultimately that will morph into a voucher. And you will give people a voucher, and they will then say, I need to find a clinical commissioning group that will cover me for the value of my voucher. And the voucher will be in some way linked to your age or your morbidity or something like that, but it's still very, very unclear. I think that's what they want to do. But of course, the complexity of doing that defies them, particularly because we have no functioning IT systems. I mean, we had an idea for a national IT system, and that collapsed with the loss of billions of pounds. Then the focus at the minute is how do you get all the providers into the private sector, and because the government all along said we're not privatising, we're happy for other groups, and they kept saying social enterprises. We want social enterprises to take over. What they didn't mention is social enterprises, corporations, and all the rest of it. And so the idea was that now, and this is one I think will come in the autumn statement, Francis Mauldin, the government will be pushing this, that all foundation trusts, which are these sort of the hospitals with more independence, will be really forced to become mutuals where they'll have some sort of employee ownership. In theory, we have one example in the UK which is presented as this. It's presented as the John Lewis model after one of the big supermarkets, which is genuine employee ownership. In fact, this particular hospital is 49% owned by its employees and 51% owned by a hedge fund registered in the Virgin Islands. Go ahead.
I just wondered whether you could go back to the commissioning groups.
Yeah, sure.
Is it true that they have got no, they've got no real structure to which they are accountable, and B,
yeah.
If the patient's got their bucket of money and they shop around, they can actually be turned down by each one of them? They
can be.
Turned down for, if you've got to say, I would like this service.
Oh, you mean as a patient can be? Oh yeah, absolutely, that's happening. So what you're having more and more is the referral management services. So if people do not meet the criteria, they're not getting the treatment. And you've got encroyed in a list of low-value treatments, which actually include a lot of things which do give people benefit. And in some places, things like hip replacements and so on are just not being funded anymore. So that's happening. There's no democratic accountability whatsoever. In theory, you see, you've got. I mean, it's so difficult, isn't it? I mean, I'm trying to make this as straightforward as I can, but it just defeats me. In theory, you've got these bits with local government. You've got Health Watch, which are the consumers, and the health and well-being boards, but they really don't function at all. I mean, it's just a mirage, and nobody really knows what they do. So I think the problem is there is a real issue of democratic accountability. They've got money. I mean, there is an issue that to spend public money in the UK or in New Zealand or anybody, somebody has to be accountable to Parliament somehow. We've long gone, I mean, even in the days of, King Charles I, for example, one of the issues why we had the English Civil War was because Charles I couldn't raise money from Parliament. Even he had to be accountable in some way, and of course he paid the ultimate penalty. But but we now have a situation where actually nobody understands where the lines of accountability are here. So, in terms of trying to explain, so I think what's happening is at the minute, they want to go for mutuals. You'll see in this week's BMJ, I've done a piece which is laying into the mutual model because I'm saying mutuals are fine if you've got a safeguard to prevent them being demutualised, because otherwise what will happen is the GPs and the clinical commissioning groups, God bless them, will, or whoever is the employees in the hospital, will be persuaded to take a quick buck, essentially, and they will then demutualise, take some money out of it, and it will be handed over to one of the big corporations. Except, and this is where I think that's not going to work, because we've just had the news in the UK that Serco, which is one of the big providers, and Serco provide everything from running prisons to schools to hospitals to, anything, basically anything that they know nothing about. The main criteria seems to be they know nothing about what they're actually doing. And they've pulled out of the contract, out of health in the UK, because these organisations saw the NHS as a bit of a gold mine. The pound signs were clicking over in their eyes. And what they didn't realise, I mean, they're terribly clever people, they must be clever because they're paid so much, what they didn't realise was that the NHS is cash limited. And it's not like the US system when we don't spend 17% of GDP on health. And they thought that they could come in and they could undercut the woefully inefficient, wasteful NHS, and they could provide a better service, and they could make money make a return on investment after paying for all the transaction costs of the contracts and all the other things that make it more expensive to do it in this way. And they found that they couldn't. They had made money in the NHS in the old days by taking a small bit, the independent sector treatment centres, for example, which were elective surgery units that the government just threw money at to get some contestability into the system. So they would maybe have 4 or 5% of the market for something or other. And yeah, that was fine, they could do that. And how they made money there was, first of all, they negotiated contracts where there was no risk to them whatsoever. The income was guaranteed regardless of the workload. They didn't do anything like what the workload really was. They took the simplest of patients, they didn't invest anything in training, and they got 13% more than the NHS got for doing the same work. So in those circumstances, you could make money. Now you say, well, they were being paid for a volume of work. How much did they actually do? We don't know, because of course it's commercial in confidence, and they're exempt from freedom of information. Except that we do, because there was one of them set up in Scotland, and they did actually answer a freedom of information request. And they looked at the percentage of hip replacements that this unit was contracted to do, and it was paid for. It was paid for all of them. How many did it do? Anybody like to guess what percentage? 60%. I have 60%. Do I have higher or lower?
7.3.
0.3. It's in between the two.
7.3.
7.3. Oh no, it's not in between the two. 4%. And it still got paid. And we have no idea what happened with the other ones. And these were being paid a premium to do it. So we, as I said, we've got one franchised hospital in the NHS, which is allegedly employee-owned. They've got 49%, but the rest is run by a hedge fund. Hinchingbrook. And again, if you just look in the BMJ, you'll see from time to time I just throw a little grenade in and say, how is it doing now, knowing perfectly well what the answer is. And it's hemorrhaging money. But it doesn't really matter to the hedge fund because they've got a cap on how much they can lose. And once they've lost 7 million, then the government picks up the tab. Now, you might have thought, of course, the whole point about bringing the private sector is that they bear the risk. But the point is that they don't bear the risk because they won't come near these things if they have to bear the risk. And it's a bit like the private finance initiatives for hospitals, which we've had for a long time. The National Audit Office said the risk transfer formula was pseudoscientific mumbo-jumbo. Because the whole point is eliminating the risk. So I think that where this is unravelling at the minute is the commissioners are realising that they're totally out of their depth. I mean, these are GPs who largely were running small businesses, like corner shops, essentially a little bit bigger, and they're suddenly being given £65 million, and they have no idea what to do with it. And they're commissioning services for diseases that they can barely pronounce. Sorry?
What's driving this? I mean,
ideology. Pure ideology. Pure ideology. I mean, a lot of my work, as you know, was in the former Soviet Union, and the parallels there are so strong. That was communism. This is rampant capitalism. But you sometimes think that there's not much difference between the two. But that's the commissioning is not working. It's meant to be that people are moving around, and they'll move the contracts, but that's not really happening. Then I think what's happening is that the big private providers are saying they cannot make the money. And they're looking around, because if you are Serco or Capita or somebody like that, and you're a big service provider, where do you make money where nobody complains? Two areas, prisons and Australian detention centres. I mean, that's great, because nobody gives a damn. The people in there, and detention centres are absolutely ideal, like the one that G4S is running in the UK, where it doesn't even have to employ staff, because it employs the detainees on £1 an hour, well below the minimum wage, to clean up and to cook and do all the other things. I mean, this is fantastic. In earlier days, we might have called this a gulag, or a prison industrial complex, or something like that. But that's great. But the difficulty is that when they get into hospitals and health services, then it's you or your parents or your relatives or something like that. And these are people who actually have the right to write to the papers or complain to their MPs. And you can't keep driving the standards down. And so they're suffering a reputational risk, and people talk. So, for example, in Western Australia, Mike Daub and I constantly exchange stories about Serco and what's going on. People know what's happening, and they're realising they're having problems. So they're just pulling out of it. So the vision that the government had, I think, was that they would go to a competing insurance model where the commissioning support units would be the insurers, and you could be registered anywhere in the country, and you would get your personal voucher, your personal health budget, you would sign up with that. Now, they will never say this, but when you read the legislation and the permissive nature of the legislation, I defy anybody to come to an... And there's nothing in the legislation that stops this happening. And there are enough things in the legislation that could easily be taken out with no controversy and would stop this, but they haven't been taken out, even though people have said, why are they there? So that's where you think this is where they wanted to go. But the difficulty is the limit on the cash limit, because you just cannot make the money out of it. And this then becomes an incredibly expensive system because of all the transaction costs that are involved in it. So, you know, sorry, go ahead.
Just wondering, where do you see the impact with regards to the specialist workforce, or even the sort of junior workforce? Because I talked to a recent SKP from the NHS, who's now working in Christchurch, who basically says the NHS is a free healthcare for everyone's dead. His colleagues are struggling to sort of stay in there because, of course, these providers are also trying to sort of screw down contracts. Yeah. When I worked in the UK 20 or so years ago, there was a big influx from like the Germans, the Spanish, and other people because they can work over there. Yeah. But that's surely going to stop.
Yeah, I think the big crisis that we're going to face is GPs, actually, because GPs are just getting fed up with this. Now, the current contract negotiation, there's so much going on at the minute, and it's difficult to try and pull it all together, but the GPs are about to take a big hit in their income, about a 15% hit. And the government has basically put in place a system so that if a general practice folds, the whole process will then have to be tendered. And there are some providers, corporate providers, that are coming in and are buying up these things and they're running them. But the problem is we've already, even though the reforms have been relatively young, already had a few cases where those corporates have realised that they can't make money and they've walked away and they've left an entire group of people without any primary care at all. And then the NHS, the other bits, have had to come in, like in Camden this happened. Sorry, please, somebody.
Sorry, I hate to interrupt. I'm actually going to address this towards the end of the talk. But I must confess I'm sitting here getting depressed and morose over the picture being painted. You can't trust the private companies that are going to stuff the system. You can't get the content of the money who's going to spend it on homeopathy or something. From yesterday, it seems that the way forward is central government funding and organisation. How are we going to get this? How are we going to get there? Do you have any idea?
I really don't, actually, and this is the problem. I mean, it is depressing, I agree. And I think people are really, really struggling with this. They're saying, you know, we've got ourselves into this mess. In a way, it took the Second World War to build the NHS. You had the emergency medical service, and it's a bit like when we've done our work looking at the expansion of universal coverage. Like I said yesterday, things like the war for independence in Bangladesh, or the military, the revolution in Ethiopia, and things like that. It is big events are often the catalyst, and there's some discussion I know about the earthquake in Christchurch and so on. So I think big events allow you to do it, but how are we going to get this back together again? I think people are really, really struggling. The other problem, this is why maybe I should have tried to structure this more, but I know that a lot of you do know a lot about it, and it could be too simplistic if I try to anticipate. But a lot of the hospitals now, of course, have got massive private finance initiative debts. So the hospitals that did sign the PFI deals, they have a problem because they are committed to paying for the real estate that they have for 30 years. They can't change a light bulb, essentially, without renegotiating the contract. They have rooms this size that are just lined with the contract documents. And so what is happening, as happened in Lewisham in South East London, was that there was clearly a mismatch between capacity and need, and they needed to change the hospital configuration. But they had a couple of PFI hospitals with totally unsustainable debts. I mean, there was no way that they could ever be viable. And they had one that was not a PFI, and it was the one that they wanted to close, but it was the one that, by common consent, was working better than all the other ones. And so that went to the High Court. Now, this was just after the Act came in, and the new Secretary of State, the High Court ruled that he had actually broken his own law. And that shows, within 4 months of the law being enacted and getting royal assent, the Secretary of State is found to have actually broken the law that he is meant to be responsible for because he didn't understand it. Yeah, how do we get, I think the difficulty is the PFIs are going to be the real problem, because everybody accepts that hospitals need to change. In fact, one of the next study we're doing in the European Observatory is all about that, the future of the hospital. And uniquely what we're doing is starting off with the clinicians involved and saying, how do you see the service changing, instead of just regarding them as like little bits of Lego you move around in a shoebox or something like that. And I have to say the difficulty in getting governments to recognise that we should do this has been quite interesting. We're going to be stuck with that. We're going to be stuck with some of these contracts. I have absolutely no idea, and we're hemorrhaging GPs. We really are going to have a crisis, because a lot of GPs are just, as I said in that piece in the BMJ, it was about putting GPs in the driving seat, and it wasn't intended that the driving seat would be to their retirement homes.
Talking about ideology, but we had your chap over here, the guy who's the quantum physicist who's now running for Parliament, and he said that the ideology thing was that they want to systematically actually just remove the NHS completely.
From, well, I think that
He wants to dismember it, and it's a long-term 20-year plan, and that is why he's going to the European Parliament. He said it's been in place for ages, and that's the whole end.
well, no, I think that's the piece that we did. There's a paper we called Opening the Oyster, and it traces back to 1985 to this document by Letwin and Redwood. And that essentially is, as you say, to get it all out and get it completely privatised. But there is a problem with that, because that's not what the British public want. And so that's what they want to do. They have to do it without telling people that's what we really want to do. And then you get into this hopeless mess when you're trying to do something, but you can't tell people what you're doing. And particularly you can't tell the people who are working in the system. And so therefore, they're sort of issuing instructions which are so at odds with what people think they're meant to be doing, that people say, you know, what do we do here? And therefore the whole thing sort of falls apart. But sorry.
We often get the word, we need, you know, there needs to be a crisis for something to change.
Yeah.
But in my lifetime, I've never known in any Western democracy a true crisis, or what actually constitutes a crisis, or how one would define it. Is it one death? Is it 1,000?
Oh no, I think we've had.
How do we define a crisis?
Yeah, no, we have had lots actually, and if you look, for example, at the Spanish NHS and the Portuguese NHS, they came about after the revolutions in the 1970s. So that was a major political crisis and a political change. And I think if you look at the strengthening of public health under Sir Donald Aitchison in the 1980s, there was an outbreak of, I think it was salmonella, in a long-term home for people with learning difficulties that was abysmally badly handled, and that was used as a crisis to turn things around. In fact, and what I'll be talking about in Auckland on Friday, what we've seen more often is the way in which the neoliberal agenda have used crises like the austerity, the financial crisis. Naomi Klein describes this very well in her book Shock Doctrine. Hurricane Katrina, how do you get rid of all the state schools and put in charter schools? How do you get rid of all the fishermen and the fishing families on the beaches in Sri Lanka so you can build your luxury hotels? And again, the coups in Chile and all the rest of it. So I think the neoliberals have very much exploited crises. I think people who are more interested in social solidarity have been less able to do it. But how do we get back? I really don't know. Sorry, sorry, go there. I'll go there because you've, yeah, please.
I think as a profession we're partly responsible. I think Chai yesterday made a very good point near the end of the day that if we don't put up a workable solution, something else will be opposed. So we actually have, as a profession, why the heck, because I was in the NHS in the 90s when primary care trusts were why the heck has that been reinvented and adopted by some of our professionals?
Well, I mean, I think what I said yesterday, I think the BMA have been lamentable. I don't think they've got it at all. And I think the problem is, part of this is that people have really had difficulty coming to terms with, could they really want to privatise everything? You know, it's been sort of, in a way, that cognitive bind that you get into. You can't think, well, there are so many examples. You know, the standard analogy is of the frog in the saucepan, and things are just, you know, heated up and it just sits there and boils, whereas if you chucked it into boiling water it would jump out. And when things just change a little bit, and also you think, well, no, they can't possibly mean that. And I know that whenever, and I think it's partly because, certainly with Lucy Reynolds and myself, if you look, we've probably written I think, the most in terms of the critiques of this, if you look at what we've published. And we were accused of being conspiracy theorists, and we were accused of, no, they couldn't mean that. And particularly, some of you know I've got a long-standing issue with the King's Fund, because I think they completely sat on the fence in all of this, and they could have spoken out about it. And it was this, that people couldn't possibly want to do that, and it was interpreting everything in the most generous way, or they're only trying to improve this, or they're trying to get GPs to have a bit more influence. And you could construct all these narratives. But I think what happened is, for those of us who worked in multiple health systems, and in particular with Lucy and myself had worked a lot with the mass privatisation in the former communist countries of Eastern Europe. And we could recognise the language, and Lucy was great on this because she was an accountant working in privatisation. She would look at a bit of text and she would recognise where it came from. She'd seen it before in Romania or something like that. The King's Fund and people and the Nuffield Trust couldn't. They didn't get that. But I think she was very good, and of course she was portrayed as being, you know, conspiracy. I mean, we were both portrayed as being conspiracy theorists. So I think the problem was people couldn't get their head around, could this government really want to do this? Because in a way the NHS, it's a bit like the Canadian health system. It's what defines being Britain. You have it in the opening of the Olympic Games. I mean, how could anybody want to do this? They couldn't possibly. They couldn't. But then I think what's also really interesting now at the minute is the blame game that's happening. Nick Timmins, who some of you know, who came here to write something about the Canterbury Initiative, not without controversy, wrote a history of some of this. And a lot of it was taken from interviews with Andrew Lansley, who was the Secretary of State at the time. And the narrative there is that Lansley was portrayed as having had a vision for putting GPs in the driving seat, and it was all perfectly sensible, and his wife was a GP and he knew the GPs around Cambridge, and it was all quite good. But then they had the pause, and he claims, or it is claimed, that they had a crisis meeting in Downing Street with Letwin, the Cabinet Office Minister, in which Lansley was excluded from the room. And then this came out. So you're seeing Lansley saying, basically, I had a perfectly good idea and they screwed it up. You're seeing the people in the Conservative Party saying, we didn't realise he was mad. Lansley, you know, and so trying to work out what's happening. I think there is a common concept, this is a dog's breakfast. And yeah, how do we get, I don't know, beyond me. Please.
On the basis of all this, is it possible to privatise medicine in any way that works?
Well, no, not really. I mean, not if you're going to want to make money out of it. I mean, if you're going to be one of these big corporations, there are lots of ways you can make money. You can invest in anything. You've got a load of money, and you can put it into healthcare, or you can put it into hotels, or you can put it into prisons, or you can put it into building bridges, or you can do anything. And you're going to say, well, first of all, I mean, it's a bit like the issue that the European Investment Bank is a partner in the observatory. So we've done a lot of work with them. If you look, I've done a couple of books on hospital design. We've worked with Arup, we've worked with architects. From my time as a junior doctor, I felt that there was a special place in hell that should be reserved for hospital architects. We were trying to... We were trying to say, well, what should a hospital look like to actually help the people who work there? You know, how should you design it and so on? And what the EIB and to some extent the World Bank, who are also partners with us, have found was, you know, healthcare is very complicated. If you want to lend for building a bridge, that's great. And they talk to their colleagues who were in the, you know, let's build a bridge or build a dam. Dams are a bit more difficult because they displace people, but building bridges are great. If you're an investment bank, build bridges everywhere. Fantastic, dead easy. You just need two bits that are at the same height and a hole in the middle, and you build a bridge. It doesn't have to be going anywhere. But trying to invest in healthcare, hugely complicated. So there's that, and then if you're not going to spend 17% of GDP on health, how do you get that return on investment? There are so many easier ways. And in the US, remember, the system only works because you've taken all the difficult bits out. Over 65, on dialysis, Medicare. Poor, multiple disorders, Medicaid. And then the private sector can do all the other bits. So they can only make money by cream skimming.
See, I mean, just looking at parallels, there's in a microcosm, there's a parallel right here, because we're currently tendering for laboratory services,
yeah.
Free district health board, private public partnerships, all that have been talked about. And the way it's potentially being solved, and there's a lot of smoke and mirrors going on at the moment, is that if you privatise, you create efficiencies, because private systems are more efficient, and you can save apparently 8% by perhaps privatising part or the system. But from what you're saying, you can't.
Well,
the driver of
yeah, you can't. No, you can't. My colleagues Sanjay Basu and David Stickler have done a systematic review which looked at this in low and middle income countries. It's just nonsense. The only way you can make money is by cutting wages. And of course, if you do that in a country like ours, what you're essentially doing by cutting the wages is that you're then getting a subsidy from the government because they make up the difference in terms of tax credits and other forms of welfare benefits and things like that. So you're just getting the government to subsidise you that way, or you're cutting services. Where they're really having a problem, it's fine if you just do a little bit of it, and there's somebody else to pick up all the other bits. But this is the problem they're facing in the UK. If you want to run the whole service, and there's nobody else to transfer those patients to, then you're stuck. But if you're doing 4 or 5% of it, then you can cream skim. What we're seeing also, and you can do other things, you can use your market power. So one of the things we're seeing in the UK in mental health, for example, is there's a crisis in mental health. Everybody accepts there's a crisis. But what happened was the private sector got into the adolescent mental health. And they moved in there and essentially got into predatory pricing, closed down all the NHS bits, and so now when you've got kids with adolescents with eating disorders and so on, the only provision is often the private sector, who are charging between $500,000 and $750,000 a year per patient. And because these are people that the system is not willing to leave out in the streets. The older people with mental health problems, the ex-service people that have got post-traumatic stress and so on, that are sitting homeless under the arches of Westminster Bridge or somewhere like that, that's fine. Nobody's making a fuss about that. But these are often middle-class kids, and somebody will make a fuss. So the state feels the NHS feels it has to pay, but it is paying an absolute fortune for that because. So but in general, what we see is the private sector comes in and it finds the simplest of things. It finds a niche where it has nobody with multiple comorbidity. I mean, that's the last thing you want. You don't want to bring somebody into your hospital bed for an elective procedure and suddenly find that they're going to have a diabetic crisis or a heart attack or something. I mean, absolutely not. It's a bit like the disease management programs in Germany. You get these sort of compartmentalized programs for diabetes, for breast cancer and asthma. What if you've got diabetes and asthma? Forget it. You don't fit in. That has to go somewhere else. So that's the problem. Markets hate uncertainty.
There's a real economic problem. What you've got is a health system which has a fixed budget. That in itself is a problem anyway. From a philosophical point of view, there's a belief that you can't increase wealth in that system. And there was an interesting documentary on comparing the English versus France in the time of the Industrial Revolution. And in the 100 years, England doubled its GDP,
yep.
France is static. And the real reason, the philosophy behind it was that France believed that the wealth was finite, whereas English people believed that wealth was actually something you could grow, and it's actually relatively new concept 200 years ago. And the very belief that you can increase and expand wealth is the thing that fueled the industrialism. Now, I think that was quite profound when I saw this program, because it suddenly made sense to me after the conversations yesterday.
Yeah.
If you believe that health is finite, there's a problem. There's no incentive for you to expand it. It has to be regulated. And if you have a private industry coming in who has a different model that wealth can be created, all they are able to do is extract wealth from within that finite budget, become very wealthy themselves and screw everybody else.
Well, that's right.
Now that's a philosophical problem. You've got two conflicting philosophies. The only way, I believe, that we can address this problem is what you said yesterday. We must see health as an investment, because that is analogous to actually seeing health as generating wealth.
Yeah.
When you see it as an investment, then all the other issues go out the window.
Yeah, but it also, the corollary of that, which I didn't talk about, but I mean, I take it for granted, is that it has to be evidence-based. You have to be investing in things that will actually achieve a gain. And this is, again, Margaret McCartney's. If you haven't read The Patient Paradox, it's worth reading. Her point that the problem we're now facing is that the expansion is all in the screening of healthy people, and you screen them until you find something that you can persuade them they need treated. And that's the simple things, because if they haven't really anything wrong in the first place, you've just persuaded them that they're ill. You can make them better very easily by persuading them that they're no longer ill. And so that's where we need things. And that's why things like NICE, for example, are under such attack from the neoliberal think tanks. They absolutely hate it because it imposes the idea of evidence and so on. And in fact, this government, we have an issue around cancer funding. First of all, the cost per QALY that the NHS will pay is higher for cancer drugs anyway. There's pressure from the pharma industry. But the government then created this alternative cancer drugs fund, which is basically a means of paying for unevaluated treatment. It's completely bizarre. You know, so, but I think we have to use effective treatment.
I just want to go back to laboratory services because they've just been mentioned. What could New Zealand do to create more of an awareness of what's currently happening? Because I think what you said before, these things are insidious. And the laboratory services problem started way back when New Zealand did what the aircraft industry did in the UK to allow a contract to happen up in Auckland with a company that didn't have blood collection centres, never mind any analysers, never mind any people to do the work. But still, they obtained the contract.
Yeah, I remember that.
And the drama started then. Now, 3 years ago, after the earthquakes, someone had a new ideology called, why don't we do what the construction industry does with health and do alliancing, and started alliancing between currently the Canterbury region, between a private and a public laboratory, with an alliance contract that's actually not a true alliance contract to begin with, which has caused an absolute chaos.
Yeah.
And the move is towards, of course, they do exactly what other private providers do. They pick on the good things, the high volume, the bread and butter, it's cheap to run, at low labour cost. We are stuck with all of this.
Exactly.
Within 5 to 10 years, we are going to be, as a government-funded institution, non-viable.
Well,
and now carry on, of course, in the Capital Coast region. No one actually seems to be taking...
well, you know, some of us, this is what we keep going on about in the observatory. You know, we point out that microbiologists and chemical pathologists and things do things other than just do tests. You know, they do advise on patients. They do actually have a clinical role. And if you just sort of automate all of this and say you can do it anywhere, then you have a problem. I think the difficulty is that because of the ideology, those people that are pushing for the contracts allow the contracts to be written in a way that that can happen. We've just privatised the Royal Mail in the UK. And it's only a few months old. It's already a disaster. So the new privatised company is trying to get out of the universal postal obligation. You know, so what had been happening was more and more foreign companies have been coming in. Interestingly enough, like in our railways, many of these companies are not actually private companies. They're state-owned companies in other states. So they're owned by the, you know, like Deutsche Bahn or EDF, Electricity de France, or somewhere like that. So they're coming in and sort of getting all the profits and subsidising electricity in France. And as we have an apartment in France, I'm delighted with that. I just, you know, have money move from one bit to the other, bit like our railways, which are keeping the Canadian pension funds going. But what they did was the private companies that came in, they were given the contracts for the bulk mailing and for the urban bits. And if you really believed that the private sector was more efficient, if you really thought it could do something, you could say, okay, you can have a contract. You do the Scottish Islands. You take that on, and you give us a price for that, and let's see how we can do it. But what they did was they said, the contract that we have to get, we will not do the last mile, as they talk about. We will only do the bulk mailing. We'll take it to the post office, to the local post office, and then the state, but they can deal with it. Now that they've privatised the whole thing, the Royal Mail is realising that it cannot extract the profits in the way that it did before, and it's coming badly unstuck. So this is the problem. You can only make money out of these natural sort of these systems if you cream skim massively and if you rig the contracts. And the other problem is, as soon as you do exactly what you've said, you get into the boundary disputes. So my wife, for example, works in occupational health. They in the NHS, and they used to have a contract for the health in the prisons in North London. And when it went out to re-tendering, Atos, which is one of the big French providers, got the contract. And then, of course, the contract had been written in such a way, there was always this sort of quid pro quo, you know, if you've got a problem, we'll try and help you, an outbreak of Hep B or something like that, we'll do something about it, and so on. And it worked very, very well. And, of course, as soon as Atos came in, no, we don't do that. That's not in the contract. So now they've gone back to the NHS and said, can you come in and help us sort it all out? It was a bit like the Olympics with G4S, where the armed forces had to come in and support them in the security because they screwed up on it so badly. So, you know, they're always dependent on somebody else. We have a classic example on the East Coast Railway line at the minute because, you know, we've privatised our railways, so we now have the most expensive fares in the world. That is a line in which they franchised the line. I mean, the whole system is weird there because effectively the railway companies say they make a loss, but they only make a loss because the train owning company, the companies that own the trains, make a massive profit, and then they bank it in Luxembourg or somewhere like that, so they don't pay any tax. So, you know, it's where the money you just have all these transfer pricing things. Now, the private operator has failed twice in this. There is now a state operation. It's the one state-owned operation in the railway lines in the UK. It's bringing in something like £17 million a year, as opposed to a subsidy of about 40 or 50 under the private ownership. And the government is going to privatise it again. Record levels of satisfaction, pure ideology.
So coming back to, I mean, this issue of ideology fascinates me. Are we just talking about modern day global capitalists who are just interested in feathering their own nests,
Yeah.
collecting, just creating as much wealth for themselves as possible?
Yeah.
This is kind of the end game of capitalism.
Yeah, and this is where I think, I mean, I'll talk a bit more about it when I'm talking about the financial crisis. We've done, as I say, my research, which started off in sort of social, economic, political transition in Eastern Europe, and then moved into other transitions like the financial crisis. And then you start getting into what actually went wrong. And you think, I mean, yeah, it is exactly that. How is it that during the year of in 2008, whenever everybody's wages were falling, the CEOs of FTSE 100 companies went up by 49%, not 4.9%, 49%. Yeah, I mean, the rules are completely rigged. I think what's interesting is that people are beginning to realise, they're reading things like Thomas Piketty's book. We're seeing in the US that the Tea Party movement, which was created with the tobacco industry, a lot of involvement by the tobacco industry, but also by the Kroc brothers and others. The individual Tea Party voters are saying, well, hold on a minute, I know that we're meant to vote for all these corporate interests and things because that will be good for America, but isn't this just welfare for Wall Street? So people are catching on a bit, but when you look at the massive imbalances, when we're talking about not the top 10% or the 1%, but the 0.01% and that concentration of wealth, and the way in which, certainly with the privatised industries, I mean, these have just been a complete rip-off, getting like happened in Russia. The Royal Mail, Royal Mail, well, the shares were sold and they were sold to institutional investors. The public got a very small amount, but about 90% went to a small group of institutional investors who we don't even know are yet. We don't even know who they are because that's commercially in confidence. And people said, the share price is far too low. And the government said, oh, no, that's all the market will bear. We've been advised by our financial advisors that that's all the market will bear. And then, within days of them going on sale, the value goes up 3 times. They make a killing. The Chancellor of the Exchequer's best man, I think it was, his hedge fund made £40 million. I ask you.
I hope you're going to be able to give this same scary talk this afternoon to the Treasury. I hope there'll be a few politicians present.
I doubt if the politicians will be there. They're always far too busy doing other things.
They wouldn't understand it.
Yeah, sorry.
Martin, we are learning from the NHS that the personal health voucher is actually existing in New Zealand health system.
Is it?
By stealth.
It's been driven by stealth in the UK too.
But it is currently in the disability sector.
Yeah, and that's where we're doing it.
And it has been promoted that it could go into chronic illness,
Yeah.
for elder health care, and ACC are really pushing this.
Yeah.
They are saying, and they have touting examples where somebody has been given effectively the voucher, and they can arrange their own home care, their own people to come and look after them, and they get the nice people, not the nasty people,
Yeah.
and all this. And in fact, this is already happening,
Well,
and it's being touted to expand.
Great in theory. Look at our paper in the BMJ and the Dutch experience. Look at the evaluation from, I think it was the UK Canterbury team that evaluated the personal health budgets in the UK. It's all smoke and mirrors.
But this is we are going down there.
But this is the thing, you see the same things happening. And again, with Australia too, there is people like these transmitters of ideas like Linton Crosby and people like that sort of migrate around the world, spreading misery and unhappiness.
But the other thing which sounds good from the non-health determinants of health. We talked about housing, we talked about all this local government stuff. Ideologically, it seems a good idea that local councils, that local governments like territorial local authorities have to have a responsibility for the health and well-being of the population.
Yeah, but they don't own any council houses anymore. That's gone.
But in New Zealand, that's a bit different.
Yeah, okay, fair enough.
And it seems a good concept if they do actually have some responsibility and some skin in the game.
Yeah.
In New Zealand, they've actually just recently legislated it out of territorial.
Have you? Okay.
As something that is upfront in their responsibility.
Yeah, I think it depends a lot on what local government does. Local government in the UK does virtually nothing. In fact, there was one of the councils in Essex which had an idea that it would meet twice a year to vote on the contracting process, and everything else would be done externally. And that they had to roll back a bit from that, actually, but that was the idea, and that was being praised by the government, that everything essentially would be run. And then the problem about this is, you know, you get into the situations like the prisons in the United States, where, you know, much of them are privatized, and then you've got a very powerful lobby for sending as many people to prison as possible, or in the case of one Pennsylvania jail, for bribing the judges to send local kids to jail for leaving their library books back late or something like that. And of course those two judges are now in jail in Florida. But you know, these are the things that happen. People respond to incentives. So I don't know if anybody's any clearer about the NHS at the end of all of that. I think it's really probably inappropriate to dignify it by trying to present. You know, one could present a sort of clear diagram which would look good on paper, but it doesn't begin to do justice to the incoherence of it. And people really are struggling to work out what it means. They just don't know. Over there and then here. Yeah.
Right, so a 6-month lag for the NHS refugees to come to New Zealand, so we should be expecting this in the next government.
Possibly, yeah. Yeah. I think the other thing that we haven't, not all of this has run its course yet, because there is the contracting out of the deaneries, and some of that's already happened, of course, and that's likely to create even more confusion. We were talking to, who was I talking to the other day about London Deanery? Anyway, the way in which the junior doctor training, I think, is going to become much more problematic, so you may well see more and more people. I'm just glad I'm retiring soon.
What's it like as a patient?
Well, you know, people make the system work. I think what people are finding is for elective surgery, they're finding it more difficult because of these Croydon lists. The Croydon CCG was one of the first, where they have the conditions of low value, as they call them, which is a lot of elective surgery. And so I think there are problems. Waiting times are going up. Waiting times in A&E departments are going up. But people still basically try and make the system work despite all of this. I think there is a worry that they're probably making the system operate in a way that probably is strictly ultra vires. I think some of the contracts probably are illegal, but nobody really knows how to make them legal in a way. That's the difficulty. And I know that the CCGs are really struggling with this. They think, you know, are we actually allowed to do this? Is this possible? And you know, they do it anyway, but they're not with any great confidence that they've actually got it right. And then, as I say, with the private sector pulling back from a lot of things, and they pulled out, like originally, I mean, Serco pulled out of ours in Cornwall, and they've, in a number of places, they have had to pull back and sort of say, you know, help, come bring the NHS back in and do it. I don't know, it's a mess.
Martin, thanks very much for your talk. I'm struck by the phrase low value.
Yeah, I know, and this is the problem.
Got two questions.
Yeah.
Who made that?
Usually public health physicians, sadly.
Low value to who?
Yeah, well, exactly, and this is a very good point. You know, this is based on this idea of going back to Jack Wenberg's work about variations and so on, and you say, well, you know, there are far more hysterectomies done in Boston than there are in somewhere else, and so on, and too many tonsillectomies and so on. But and then you say, well, just because many of these may not be clinically appropriate, we'll stop doing them all entirely. And this is the difficulty. It takes any clinical judgment out of it. And I have a real problem. I think in public health, my colleagues in public health have been complicit in this. I've elsewhere argued that public health hasn't always had a good record in standing up for the public as opposed to the state. I'm thinking of some of the excesses in Nazi Germany, for example, the control of tuberculosis in Poland by killing Poles, which was perhaps not one of our finest moments. And so I think we should not have engaged. We should have said, well, actually, clinical judgment still is important, rather than having these blanket bans. I have a big problem with that. Okay?
I would be staggered at what the cost is of running this drug order.
It's massive, massive. Nobody really knows, but it is massive. I mean, there are armies of people just pushing documentation back and forward to one another. It is absolutely unbelievable. The management costs have gone up beyond all recognition, if anybody knew, because the accounting systems aren't even working. And then just the cost of redoing the stationery for the new organisations and the signage and things like that. That in itself is actually a significant amount, a non-trivial amount. And then, you know, people don't even know who they work for anymore. This is the thing. It's complete and total confusion. And yeah, I don't know. I mean, there are people who will try and say, well, the theory is this, you know, and so, but the practice is that people are making it work by informal, you know, God, let's try and hold the system together. Yeah. Okay. Well, I'm going to come on to that in social media in a minute. Compared to what I get from other people, yeah, this is trivial, but actually not so bad, because in this, there was a bit of it at the beginning. It was, well, he doesn't understand it. But it was fairly gentle like that, because I don't think they really wanted to. There's been a little bit from some of the people like Hinchingbrook, for example, being quite critical, but it's actually fairly mild. And then the other hand, I can say, well, actually, my credentials are quite good. I sat on the medical advisory panel for Bupa, the biggest private insurer, for 12 years. You know, it's not as if I'm some card-carrying Marxist or something like that. I have no problem in working with the private sector where I think it's doing a good job. I mean, I don't have an ideological issue about this. So it's a bit difficult to criticise me on those grounds, whereas there are other people like Alison Pollock, it may be more. Wait till you hear the later. We'll come on to that later. Okay, sorry, one final one, maybe it's a good time.
Yeah, just a quick question. You made me feel very grateful that I moved from the NHS 10 years ago, so thankful for sitting here. I keep in touch with a lot of my friends, hospital specialists across there still. And I just ask, because we haven't really sort of touched on that during your talk, is the morale of hospital specialists out there, where they see themselves in all this picture. And I mean, I speak to them regularly.
Yeah.
I get mixed opinions. I can't really judge where that workforce attitude sits right now.
No, I think many people just keep their heads down. And there's the classic line whenever New Labour was bringing in the reforms, and Alan Milburn, the Secretary of State at the time, made a speech to, I think it was the Royal College of Nursing, and said that he was going to abolish the internal market. And somebody piped up at the back and said, Secretary of State, I've been a ward sister for the last 20 years. What is this internal market? And you know, often if you're going to your clinic and doing all the things, you may not notice this. You may think just the paperwork's got a bit more, or it's a bit more difficult to get things done or something like that. So I don't think it's hit yet. There is, of course, the new consultant contract that hasn't been concluded yet. That may, I think people may leave after that, and the pension changes haven't helped either, and that was done on the basis of a lie as well. You know, even in the report it showed that the cost of the pensions would be going down after a brief bump, and yet it was misrepresented as some crisis. So there's a number of reasons why I think many people have got disillusioned, but they're sort of making it work. But given the amount of resources that have been put into this, we could have achieved a hell of a lot more. And so much of it has been wasted. There's been a huge hemorrhage of talent. A lot of managers have taken early retirement and then been reappointed. The cost of that has been phenomenal. So, yeah, it's just been crazy. Thanks.